Hello, how's everybody doing today? Welcome to class. It is week 14. We only have 4 more live lectures left. You're about done with this semester. Congratulations, everybody. Hope you're doing well today. Good morning, Caitlin. It's good to see you. Looks like we've got about 5 viewers here. Fawn's here. Luke, good to see you. Good to see everybody. Welcome to class. I hope you're ready for a nice summer break. If you haven't already, sign up for your summer classes. So far, a lot of the classes are still open, so you can get the teacher that you're interested in or the time slot that you're interested in. So don't hesitate and sign up today. Hi, Whitaker. Good to see you. Good to see you. I hope everybody had a great weekend. So today we're talking about Chapter 14, Psychological Disorders. Ow. So what we're going to do today is talk about the difficulty of diagnosing disorders. We're going to talk about the system and book related to diagnosing disorders. We're going to talk about the categories of psychological disorders and the process of diagnosing psychological disorders. I see we've got Bola and Kira in the room. Welcome, welcome. Good to see you as well. So let's go ahead and get started if we can. And Ryan, always Ryan. Hi, Ryan. Good to see you. Welcome back. Hope you had a great weekend. Hope Ramadan is going well for you, my friend. Ramadan Kareem. See, I remembered what you told me. Okay, so let's go ahead and get started. If we can. All right. All right. Let me get my board organized here. All right, so let's talk a little bit about the people who are engaged. Oh, before we get started, I do want to, oh my goodness, I do want to make one point. I am not a clinical psychologist, okay? Now, I do have a PhD from a very good university, the University of North Carolina at Chapel Hill. A lot of my colleagues are quite famous in the field of social psychology, and I have been well trained in the field of social psychology. However, I am not a licensed clinical psychologist, okay? Just like you wouldn't go to your podiatrist, your foot doctor, and try to get advice on a heart condition, okay, you would not come to a social psychologist to get advice on a clinical psychology problem. All right? So, the reason I say that is because I'm going to give you an introductory lecture in clinical psychology. However, if anything I say disagrees with what your licensed clinical psychologist says, you are to listen to your clinical psychologist and not me. In fact, if I were you, I wouldn't even go into my clinical psychologist and say, my psychology teacher says. Okay? So I hope everybody understands that what I'm doing is giving you just a basic introduction to the field of clinical psychology. Do not take anything I say as diagnostic or clinical or treatment advice. Is everybody okay? Does everybody understand that? If you would, please type in the chat bar right now that you understand what I'm saying. Okay? It's very important that you know this. All right? So I'm going to wait and see if we can get some people typing in the chat bar. Okay. Fantastic. Just so you understand, this is an introductory psych lecture and not a professional clinical evaluation. Okay? All right, so who are the people who are going to treat you if you have a psychological, if you want to get treatment? We can typically think of 3 broad subfields as being those who you would go see if you're having some sort of psychological issue that you want treatment with. We have psychiatrists, clinical psychologists, and counseling psychologists. Now, I'd like to start with psychiatrists. Psychiatrists are actually not trained psychologists. So a clinical psychologist and a counseling psychologist go to graduate school in a psychology program. A psychiatrist, on the other hand, goes to medical school and learns how to be a doctor. And a psychiatrist is nothing but a medical doctor who specializes in disorders related to the nervous system. Does that make sense? So a psychiatrist is actually not trained as a psychologist. They are trained as a medical doctor, and they specialize in disorders of the nervous system. So some medical doctors become podiatrists or foot doctors. Some medical doctors become cardiologists or heart doctors. Some doctors become psychiatrists. They specialize in disorders of the nervous system. Now, the difference between a psychiatrist, let me now talk about a clinical psychologist and a counseling psychologist. A clinical psychologist and a counseling psychologist actually go to psychology graduate programs. They don't know much about the biology and physiology of the human body. They do not. Instead, they focus solely for several years on treating people with psychological disorders. Now, in some ways, this makes them better than psychiatrists because they actually spend more time thinking about diagnosing psychological problems. The only difference is the psychiatrist is the one who is allowed to administer medication. So if a clinical psychologist thinks you need a pill or a medication of some sort, they have to consult with a psychiatrist because the psychiatrist has training in the physiology of the human body. So clinical psychologists treat psychological disorders, and counseling psychologists treat adjustment problems. So if you're depressed, if you're bipolar, if you're schizophrenic, you're probably going to go see a clinical psychologist because they treat psychological disorders. Typically, a clinical psychologist will focus on an age group and also a disorder type. So you might find a psychologist who focuses nothing but on childhood problems. Or you might find a psychologist who focuses on schizophrenic patients or bipolar patients. In fact, it's considered unprofessional for a clinical psychologist to treat someone outside the area of their specialization. So I have a friend who is a clinical psychologist who focuses on childhood disorders, namely ADD, anxiety disorders, and school phobia disorders. If you came to him and he could tell that you had schizophrenia, it would be professionally responsible for him to actually refer you to a psychologist who focuses on schizophrenic disorders. Does that make sense? So your clinical psychologists focus specifically on a general type of disorder that they have a lot of experience in. Now, some of you may go to a counseling psychologist. Counseling psychologists may have a PhD or they may have a master's degree, and they treat what we might call adjustment problems. So problems with environmental factors. Maybe you're having trouble at school, maybe you're having trouble with your romantic partner, maybe you're having stress-related disorders. You would go to a counseling psychologist, either a marital counselor, a family counselor, or just a health counselor, okay? Usually your counseling psychologists do not treat more serious psychological disorders. So those are the three broad groupings of psychological professionals that you would be going to see if you have some sort of problem that you'd like help dealing with. Hope that makes sense to everybody. Now, here's the thing. It sounds, when I describe a psychological disorder and the characteristics of it, it sounds like it's really easy to diagnose a psychological disorder. But people differ and are so odd and so unique that it's really hard to tell whether or not someone has a psychological disorder. So how does a clinical psychologist go about deciding whether or not you have a psychological disorder? The first thing they really ask themselves before they give you a label is whatever problem you're having impairing your functioning, okay? Now, they're looking for one of four characteristics when they decide whether or not you have a treatable disorder. They want to know, does it deviate from cultural norms or what is acceptable? Is it maladaptive? Does it cause you distress, or is it dangerous to other people? And does it cause discomfort and concern to other people? So we asked the question, does it deviate from cultural norms for what is acceptable? Let me give you an example. I talked to a gentleman this weekend that told me his family was concerned because they have an uncle who is 45 years old who sleeps with his 69-year-old mother every night. What do you think about that behavior? Does he have a psychological problem or not? He's a 45-year-old man who sleeps with his 69-year-old mother in the same bed every night. What do you think? Is that odd? Hi, Yasmin. It's good to see you. I'd be curious. Does that deviate from cultural norms far enough that we should say that that person has a psychological problem? It's pretty odd, isn't it? Very, very odd. And it causes the family great discomfort and it concerns them. So his characteristic behavior deviates from cultural norms and it causes discomfort to other people. So you might come to the conclusion that this gentleman has some sort of psychological problem. Yes, Ryan, I would agree with it. Now, the second thing is it maladaptive? That is, does it cause problems? Does it cause problems? So if you're too anxious to go to school, or you have claustrophobia and you can't get in your car to drive to work, then your behavior is maladaptive. It's preventing you from doing what you need to be doing. And the third one is, does it cause you personal distress? If you're depressed and it makes you sad and you lay around crying and think about suicide, we would say that your particular problem causes you personal distress. So when you go into a clinical psychologist, the first thing they're going to do is to ask you to tell them what's bothering you. That's called the presenting problem. If the presenting problem deviates from cultural norms or causes discomfort to other people, if it's maladaptive and prevents you from being a successful human being, or if it causes you distress, then the psychologist decides that you have a psychological disorder, and they go to the second step, which is trying to figure out which particular type of psychological disorder you have. So really, with the psychologist, the first thing they don't do is try to label you and put you into a category. The first thing they try to do is to find out if your psychological issues impair your functioning. Now, if you're just an oddball and different, and your behavior doesn't impair your functioning, doesn't cause you stress, and it's not too outwardly odd, then you don't have a psychological disorder in the eyes of a clinical psychologist. So this is sort of the first step that they engage in the diagnostic process. Now, what causes psychological disorders? Man, that is a million-dollar question. Psychological disorders have very complex issues that we do not fully understand. As you've known for the entire course of this semester, I will tell you that there is some things we do know about human psychological functioning, but there's still more that we don't know. So it's really hard to tell what causes psychological problems. Now, we know that some psychological disorders can be traced to genetics or brain trauma, CTE, chronic traumatic brain injuries, right? We know that there are genetic factors with psychological disorders as well as personality and intelligence. So we know that some sort of biological causes can be implicated in psych disorders. But we do also know, if you remember from chapter 6, behaviorism, when we talked about little Albert and how he was taught to have a phobia, we know that human beings, through environmental exposure, can learn behavioral patterns which are maladaptive and dangerous. And that we also know that the incidence of psychological disorders differ based upon income level, gender, and race. Did you know females are more likely to be depressed or anxious than are males? Males are more likely to be schizophrenic or antisocial than are females. So there are gender differences, there are racial differences in psychological disorders, and income level predicts psychological disorders. Now, one model that your book does talk about is called the diathesis stress model of mental disorders, and this was developed within the context of trying to understand schizophrenia. Now, the deal is schizophrenia has a strong genetic component, but it doesn't usually appear until the late teens or early 20s. And doctors were quite flummoxed. They said, how can you have a disorder which is genetically caused, that is biological, and yet it doesn't come on till 18 or 20 or 25 years of age? And what psychologists have developed is a model which tries to show how genetic causes and environmental causes can work together to cause psychological disorders. CBD. There are people who believe that CBD does help some psychological functioning. Yes, Ryan, although I don't know enough about that to answer that question in good detail. So yes, women do tend to express depression more often than men. In fact, what they talk about is internalizing versus externalizing disorders. Internalizing disorders, which are usually related to thinking about yourself, like anxiety and depression, you will see more commonly in females, Kira. However, externalizing disorders, disorders in which people act out, like antisocial personality disorders or schizophrenics who act out with really odd and crazy behavior, are disorders that you're going to see more commonly in men. So men tend to act out, have externalizing or acting out disorders, and women tend to have more neurotic or internalizing disorders than do men. Now, the diathesis stress model kind of shows you how we can work the environment and genetic causes into a psychological disorder. And so what they suggest is that some people are born with a genetic predisposition, and then childhood or actually later trauma can cause this disorder to sort of kick off. So you have the diathesis, you have the vulnerability to the mental disorder. And then what happens is when you become a teenager, life becomes more stressful, and this stress acts on this diathesis to create the psychological disorder. So you may have a genetic predisposition, you may have some sort of physiological or biological trauma on the brain. These work together to create a predisposition for a psychological disorder. And then when you meet stress in the world, the stress causes that diathesis to turn into a psychological disorder. And this is what people think happens with schizophrenia. You're born with the genetic predisposition. You may have some sort of brain trauma which causes the damage. And so you have a predisposition for psychological disorders, the psychological disorder called schizophrenia. Now, when you grow up and you're 18 and 19 and 20, you now start having all these adult stressors, job, economics, relationship pressure. And these pressures finally cause this diathesis to turn into a psychological disorder. Does that make sense? And as I said, this model was developed in the context of schizophrenia because schizophrenia has a highly genetic component, and yet we rarely, if ever, see it in young children. It always waits till late adolescence or early adulthood to appear. And I don't have it in front of me, but we'll talk about it on Wednesday. Men tend to develop schizophrenia a little bit younger than do females. So for your men, it'll be in the late teens, but for your females, if they develop it, it tends to develop 4 to 5 years later in the early 20s. Childhood trauma it's not necessarily, it can be abuse that changes the functioning of the brain as well, Kira. That's a good point. One of the things that biological differences that they've noticed in brains of people with schizophrenia is that they tend to have less cortex space. They have bigger holes in the middle of their brain. You actually have these holes in the middle of your brain called ventricles, and that's where brain fluid, the cerebrospinal fluid, is actually made, so it can circulate around your brain. And it turns out that people with schizophrenia tend to have bigger holes in the middle of their brain. They have less brain cortex. So you can think of physiological trauma that leads to brain damage, or you can think of abuse that also leads to the change in the way the brain functions. That's a very good question, Kira. Very, very, very good question. All right, now let's talk about the modern approach to disorder diagnosis. Now, it's kind of crazy. You can think of the evolution of psychological disorders as sort of going in three sort of phases. Back before the 1800s, 1700s, 1600s, 1500s, if you had a psychological disorder, the most common way to think of people with psychological disorders was that they were somehow possessed by demons and devils. This was a pre-scientific period, and you might call this the witchcraft model. So if a person was schizophrenic, they were possessed by a demon or a devil, and you sent them to the priest to get cured. Now, in the late 1800s, really highlighted and brought about by Freud, was the idea of the case study method. And what they would do is they would study individual people and their symptoms and sort of come to this idea that this particular person's mode of functioning was somehow disordered. And they didn't really have a description of all kinds of different disorders. They just studied each person individually as sort of a case study of what, and decided that this person either had a psychological disorder or didn't have a psychological disorder. And in the idea of Freud, he wouldn't talk about you having symptoms or a particular type of disorder. He just decided that you had some sort of problem in your upbringing which caused you to have disordered thinking. Now, in the modern approach, the clinical model, we actually decide to look at people in terms of symptoms, just like medical doctors do. When you go into a medical doctor, they ask you what your symptoms are. They then use the collection of symptoms to decide what particular problem you have. Now, that's how we do it today. You go in, the doctor may decide that based on your presenting problem, that your behavior is maladaptive or counterproductive or just too odd, and may say, you know what, I think this person has a psychological disorder. They then go in and look to the symptoms to decide what your collection of symptoms say you have. Now, the father of modern psychology is a fellow named Emil Kraepelin, and he was the first person to suggest that we focus on symptoms rather than individual case studies. And he suggested we use a classification system. He was the first to suggest the use of a classification system. Now, he did not invent the Diagnostic and Statistic Manual, but he gave the insight that would later lead to the development of the DSM. And he really first thought we should he sort of came up with a bimodal classification system. He thought that people really had disorders of thought or disorders of emotion. This would have been sort of the earliest way of classifying symptoms. You either had a thinking disorder or you had an emotional disorder. And he was the first to identify the symptoms of schizophrenia. He called it dementia praecox, which was early dementia. It's now known as schizophrenia, but he was the first to identify the symptoms of schizophrenia. Now, later on, this was not Emil Kraepelin, but later on, when psychology became professional after World War II, a book was created and a system of diagnosis was created in order to make the diagnosis and treatment of psychological disorders more systematic. And the DSM borrowed a lot from the medical tradition, the medical tradition, to create their model for diagnosing psychological disorders. Just how medical doctors go through and look at your symptoms, may look at your blood work, and may talk about things like prognosis, what's likely to happen if treated, if not treated. Psychologists thought that it would be good to have that sort of systematic way of diagnosing disorders in order to most accurately diagnose and effectively treat psychological disorders. Now, it was introduced in 1952, and the DSM is a system and also a book that describes this system. Now, it's now in the fifth edition, and it provides a systematic and potentially scientific approach to diagnosing psychological disorders. Now, if you look in the DSM, and I actually have a copy of the DSM-5 right here for you. Let's see, you can see it, okay. Now, if you look in this book, in the first chapter of this book, right here, it tells you how to use the book. Because as I said, this is not just a book of symptoms, it's a system. So the first chapter tells you how to use the system. Now, the meat of the book, probably this much of the book, is filled with chapters, and each chapter has a different set of diagnostic criteria and lists all the different psychological disorders you can have, and it provides lists of symptoms that psychologists learn so that they can diagnose these specific disorders. So there's an entire chapter in here on all the different ways you can have too much anxiety. There's an entire chapter on all the different mood disorders like depression and bipolar that you can have. There's an entire chapter on thought disorders like dementia and like schizophrenia, all the different schizophrenic disorders you can have. There's an entire chapter on disorders that affect children, like learning disorders, school phobias, and stuff like that. And so there are a bunch of chapters, and each of these chapters has a list of disorders, and under each disorder, there's a list of symptoms for each disorder. And when you go in and start describing your symptoms, the doctor compares what you describe to the different lists of symptoms to decide which diagnosis you have. So that's sort of the middle part of the book. And then the third part of the book, probably the last about this much, is the research issues that are of interest. And basically what that means, that's the part of the book where they talk about whether or not they need to change diagnoses and what the research suggests on whether or not diagnoses should be changed. I will tell you, as a way of sort of explaining how diagnoses can evolve, it turns out that until the third edition of the Diagnostic and Statistic Manual, the DSM, homosexuality was considered a psychological disorder or a mental illness. If you were homosexual, you were considered to be mentally defective. Now, in the second version of the DSM, they had a part where they talked about whether or not they should change the diagnosis for homosexuality. And so homosexuality was a mental illness in the second version, but it was changed. And in the third version, homosexuality was taken out of the book as a form of psychological disorder. All right. Now, in the DSM-4, here's another example. In the DSM-4, you could have autism, or you could have, oh my goodness, you could have autism, and I forget autism, oh crap. There were autism versus another disorder that was only a problem with social functioning. And they changed it from having two different diagnoses to having what they call the autistic spectral disorder, where they said that instead of having different diagnoses for autism, They lumped it under one particular category. And so every 10 years or so, they update the DSM, and during that intervening 10 years, research is done to make sure that the categories of diagnosis are as accurate as possible. And the back part of the book is where they discuss these upcoming issues. All right? Does that make sense so far? I hope I haven't lost anybody yet. Now, psychologists have adopted what they call the medical model, which is they use the terms and concepts from the medical field as the basis for using psychological disorders. This was done to improve diagnostic accuracy and treatment efficiency. Hopefully this makes diagnosis and treatment more consistent and effective. So when you go into a clinical psychologist office or a psychiatrist office or a counseling psychologist office, what they're going to do is they're going to conduct a very thorough 360-degree evaluation of your functioning. What they're going to do is you're going to come in and tell them how you're feeling. That's what we would call a self-report. So you're going to come in and you're going to tell me what problems you think are going on in your life, and I'm going to take very good notes and as you self-report your problem. Now, here's the thing. I'm also, maybe, if it's appropriate, I'm going to talk to people who know you. So this is done a lot of times by child psychologists treating children who have school or other social-related phobias. I may interview your mom, your dad, your brothers and sisters. I may interview your teachers. And so I ask everybody else to give me their opinion of what's going on with you. So I'm not just going to take your word for it. I'm going to talk to the people who know you to see if what they say is similar to what you say, or if it differs and how it differs. And so we're going to use interviews from other people as well as your own self-report. And then you know what? I, as the doctor, am going to observe your behavior. How anxious do you look? How well do you speak? How well do you keep your thoughts together? I'm going to observe you myself, right? And then I'm going to give you psychological tests. Remember last week we talked about self-report and projective personality tests? When you go into a clinical psychologist, as a general rule, you will be given a battery of psychological tests. Some of those tests will be self-report tests. Some of those tests will be projective personality tests. And you know what? There are tests for anxiety. There are tests for depression. There are tests for bipolar disorder. There are tests for personality disorders. There are tests for self-esteem. There are all kinds of psychological tests. And in fact, I've got the DSM paperwork for a student of mine's child. She gave me many years ago. It was an 11-year-old child who was suffering in school. And she did 32 different types of psychological tests as part of her evaluation. And this is all what we would call the assessment process. The assessment process. Now, after the psychologist listens to your presenting problem, that is, you tell them what your problem is, and they do that full assessment where they engage in evaluating you in this 360 degree perspective. What they're going to do is they're going to engage in what's called a differential diagnosis. So if you go into a doctor and you tell them that your knee is hurting really bad, your doctor knows that there are several different problems that can be wrong with your knee. You can have a broken kneecap, you can have a dislocated patella, you can have a torn ACL, you can have a torn MCL, you can have a muscle tear, and you might have broken your leg. There are 5 different things that could be causing your knee to hurt. Now, just like a medical doctor goes in and figures out which one of those disorders diagnosis is most appropriate, that's called a differential diagnosis, the clinical psychologist will do the same thing. So what exactly what kind of anxiety problem do you have? Is it a phobia? Do you have generalized anxiety disorder? Do you have, are you having panic attacks? And so the differential diagnosis is just figuring out which of several different similar problems you have. So, people who have bipolar disorder sometimes experience very depressive symptoms. Sometimes people who are depressed are so down on themselves that their behavior actually looks schizophrenic. They look like they are psychotic because they are so negative about themselves. And so the assessment process allows me to engage in a different differential diagnosis. And in each chapter, so I'm looking at feeding eating disorders right now. So I'm looking at feeding eating disorders. Do you have anorexia? Or do you have, let's see, bulimia, right? Or do you have binge eating disorder? There are 3 different ways you can have an eating problem. And each one of these disorders is going to have a list of diagnostic criteria, which is the list of symptoms. It's going to have a description called the diagnostic features, which tells me what it should look like, and the associated features that tend to occur when you have that, how often, the prevalence of it, and the development, so I can ask you how it's changed and I can get some more clues. And all of these clues for each of these disorders allows me to differentially diagnose the problem so I can come to a most accurate description of what your psychological problem is. Does that make sense? Now, also inside this book, we're going to talk about incidence rates. So just as we know how often people have heart attacks or cancer or gallbladder problems, or etc., we know the typical incidence rate for how often psychological disorders happen. In fact, depression is called the common cold of psychological disorders because it is so incredibly common. It has a way higher incidence rate than, say, schizophrenia. So I think what they say, 8 or 10% of people are going to suffer from a depressive episode at least once in their life. But only 1 in 100 people, 1% of the population, will develop schizophrenic or psychotic symptoms. So we know that the incidence rate is much higher for depression than for schizophrenia. And then, although this is a little bit more difficult, psychologists also talk about the etiology, or the causes of issues. If you really want to fix a problem, you have to know what causes that problem. And this is where psychology is a little bit weak right now, because we really don't know 100% what causes schizophrenia, what causes depression, what causes bipolar disorder. But to the degree that we know what the cause is, we can better treat the problem. And then, just like a doctor can tell you what your prognosis is, what's likely to happen if you don't treat the problem, and what happens if you do treat the problem. So if you have an ACL and you get surgery, your doctor knows that in 6 to 9 months, you will be back to normal if you go through this physical therapy. If you have cancer and you don't treat it, you will die. But if you go and get treatment for cancer, for example, the cancer that I had, with radiation and chemotherapy, I'm 90% likely to survive the cancer that I have. That's what we would call my prognosis. And just as medical doctors talk about presenting problems, what's hurting today? My knee's hurting. Just as a medical doctor engages in an assessment, let me do an MRI or an X-ray, a clinical psychologist engages in an assessment. Just as a medical doctor decides exactly what medical problem you have, a psychologist engages in a differential diagnosis. Just as we know how often people have medical problems, we know how often they have different kinds of psychological problems. Just as medical doctors like to know why a problem occurred, clinical psychologists like to know the etiology or causes of a problem. And just as a medical doctor knows what's likely to happen if you do or don't treat a medical problem, a clinical psychologist has an idea of what's likely to happen if you do or don't treat a psychological problem. Hope everybody understands that. Hi, Leanne. It's very good to see you. Thanks for popping in and saying hello today. Folks, Leanne is one of my clinical psych, my developmental psych students. Now, what I want you to do is look at this book, this picture right here. This is in your textbook, and this represents all the different kinds of, this represents all the different chapters that you're going to find in the DSM. So there's a chapter on neurodevelopmental disorders, children disorders. An example would be autism. There's a chapter on schizophrenic and other psychotic disorders. There's a chapter on bipolar disorders. There's a chapter on depressive disorders. There's a chapter on anxiety disorders. And so each of these categories on the left represents an entire chapter in the DSM, and each chapter is going to have many examples of specific disorders. So for example, you can have bipolar 1 disorder or bipolar 2 disorder. Bipolar 1 disorder is bipolar disorder that's more characterized by depressive symptoms. Bipolar 2 is a bipolar mood swing disorder that's more characterized by manic swings. Okay? Oh, look at that. I also have a professor friend of mine stalking today. Holy cow. This must be visitor day in Psychology 150. If I say anything wrong, Professor McCoy, please make sure to correct me, okay? You know I hate making mistakes. By the way, folks, Professor McCoy makes some of the coolest psychological intro psych videos that I've ever seen. He does recorded videos, but his videos are the highest quality in terms of production quality and content. Really good stuff. The collection of disorders, and for each of these disorder lists, you're going to get the diagnostic criteria, the prevalence, the developmental course, the risk factors, how you can tell it from other disorders, and what kinds of disorders it tends to co-occur with. So for each disorder, like schizophrenia, bipolar, or major depressive disorder, each disorder description is going to have these 6 characteristics listed inside that particular disorder description. Okay? Now, I did want to make one short statement about comorbidity. Comorbidity, it turns out that sometimes when you get one disorder, you will tend to get other disorders that occur with it. So if you suffer from obesity, let's talk about a medical condition. If you suffer from obesity, you are likely to develop the related condition of high blood sugar, which could lead to diabetes. Now, obesity is different than diabetes, but a lot of times when people are obese, they may have high blood sugar. So if you go into a medical doctor's office and you are obese, they will check to see if you have high blood sugar, because high blood sugar is a comorbid condition and a unique condition that tends to co-occur with people who have obesity. And so just like there are comorbid medical conditions, there are also comorbid psychological conditions. And what I'd like to do is talk to you specifically about anxiety disorders. It turns out that people who have generalized anxiety or panic disorder, now panic disorder, people think of them having just a breakdown, a huge sympathetic nervous response where their heart starts beating out of their chest and they start breathing too fast and they feel like the world's pressing down on them and they have just this feeling of terror for maybe 5-10 minutes. That's called a panic attack. A lot of times people who have panic disorder will also develop a comorbid condition called agoraphobia. And agoraphobia is think of that as a fear of leaving your house. And the reason that people with panic disorder develop agoraphobia is because they're afraid to leave their safe space where they might have a panic attack. Now, agoraphobia is completely different than panic disorder, but it develops in context of panic disorder because people feel not wanting to have a panic disorder causes them to develop this particular phobia. Does that make sense? Does that make sense, folks? Now, if you look right here, here are the different kinds of anxiety disorders that you might find in the anxiety chapter. So the anxiety disorders, so you have anxiety disorders, you can have obsessive compulsive disorders, you have post-traumatic stress disorders, you can have depressive disorders, and bipolar disorders. Oops, excuse me. So the first three are going to be anxiety-related disorders, and 4 and 5 are going to represent mood disorders. So inside each of these different disorder families, you're going to see specific ways that you can demonstrate it. So for an anxiety disorder, you can either have too much anxiety related to a particular target, so you could have a phobia, or you could have just too much generalized anxiety and you're just anxious all the time, and that's a generalized anxiety disorder, or you might have panic attacks. So each one of these specific disorders might be the focus of what we would call a differential diagnosis. So I know you have too much anxiety. Do you have a phobia, an anxiety, a generalized anxiety disorder, or do you have panic disorder? So what we do is we look inside the family and we try to do a differential diagnosis to find out exactly what psychological disorder you may have. Now, on Wednesday, we're going to talk specifically about one family of psychological disorders. We're going to talk about schizophrenia or thought disorders more generally. Or psychotic disorders. So we're going to talk about disorders involving psychosis on Wednesday, and we're going to get into this idea of, and we're going to talk a little bit about bipolar disorders, and we're going to get into the idea of characteristic symptoms, diagnosis, prognosis, and incidence rates. And we're going to talk about the details related to schizophrenia and bipolar disorders on Wednesday. Well, that's all I have to say for today's lecture. Does anybody have any questions before I let you go? I'd like to thank everybody for showing up. I'd like to thank my guest, Leanne, who popped in. She's one of my leaders in my developmental psychology class, and Dr. McCoy, who is a friend and a colleague who I like to collaborate with. I hope you learned something today. I look forward to seeing you on Wednesday. Till then, if you need any help, don't hesitate to send me a text or an email. Have a great day, and I will see you on Wednesday.